Okay, all good? All right, I'll start letting everybody in.
Welcome, everybody. We're just going to give it a few more minutes to let everybody come join us, and then we'll start shortly. Hi, everybody. It's just a little bit after 7:15. We're going to give it another minute or so just to make sure everyone arrives at is planning to, and then we'll get started. All right. Well, just in terms of time, because we have lots of great information to go on tonight, we might as well get started here. It's a little bit after 7:15, our start time. So welcome, everybody. Thank you for joining us for another town hall hosted by the LMPCA, the London Middlesex Primary Care Alliance, here tonight to talk about the new antiviral treatments for COVID-19 from a primary care perspective. My name is Vineet Nair. I'm a family doctor and co-chair of the London Middlesex Primary Care Alliance. And we're really excited to have a great evening of education for you with some great speakers to cover some really important information. Next slide. Sorry, next slide, Adrina, if you can.
See the housekeeping slide?
I can't see it, no.
You might need to share the presentation mode.
Yeah, I am actually in presentation mode.
Well, we're one of the things, well, the next slide is about housekeeping, which is really just about some general housekeeping things for all of these talks. So just to ask you to be on mute, so you don't have any background noises that might be distracting to everybody. We will be using the chat feature tonight, so please make use of that. You know, ask any questions, let us know who you are. I'd like to see everybody's names and get to know people a bit better. We will be posting things in the chat as well, some documents you can download, some links that'll be useful for you. So please keep a lookout on that. There'll be lots of time for questions at the end, but if you have questions you want to ask, please do that in the chat as well. And when we do get to the question and answer period, please just raise your hands. We know that you are interested in asking a question. That's great, Dina. Thanks. We are recording this talk today, so please be aware of that. And we will be sharing the recordings with the attendees tonight, as well as any links. Next slide. So as I said, this is a London Middlesex Primary Care Alliance hosted session. Reminder, we are an inclusive network of primary care providers that are leading with a unified voice to improve the health of our community. We really are trying to be a resource for primary care so that we can provide information like this, but also to be that voice so that people that want the primary care input in whatever project they're doing, that we can be a resource for that. You can read our mission statement there as well. Next slide. So tonight we are talking about these new antivirals for COVID-19. We'll be covering a lot of topics here tonight, the mechanism of action, evidence in clinical trials, pharmacology, and how to access these drugs for your patients. And to help us with that, we have lots of great speakers here tonight. Next slide. So we have Dr. Megan Devlin, who's an assistant professor in infectious diseases at Western. She's co-creator and co-lead of the LHSC Urgent COVID Care Clinic. We have Dr. Samir Elsayed, who's also an infectious disease specialist. He's a consultant in infectious diseases, internal medicine, and medical microbiology at LHSC and St. Joseph's, as well as professor of medicine, pathology, and laboratory medicine, and epidemiology and biostatistics at Western. We have Rita Dhami, PharmD, clinical pharmacist in antimicrobial stewardship and infectious disease. And we have Dr. Gord Schacter, who who many of you already know is an executive member of the LMPCA, but in this role tonight, he's speaking perhaps more as the London Middlesex Pandemic Clinical Lead, which is an OHT-funded position to ensure that the primary care voice is present at this important table. So it is great to see that kind of leadership being funded. So with that, we'll get started with our talks, and we hand it over to Megan. Dr. Devlin.
Great, thanks, Vineet. So as Dr. Nair has mentioned, I have been running the LHSU Urgent COVID Care Clinic for the last 2 years, which means that I've spoken with a lot of outpatients in the community with COVID, and I know that many of you have been supporting these patients as well through your practices. So I wanted to thank you guys for taking time to learn more about the new therapies that are available. Next slide. So our evolution in terms of treating COVID over the last 2 years, it's changed a lot. But as we talk tonight, we're focusing on the early stages of the illness and thinking about therapies that are going to impact on the initial stages of COVID infection and who's going to most benefit from those therapies. And this is a very old slide now. So next slide we're going to go to. All right, so when I think about prescribing for COVID outpatients, and I know many of you are already doing an excellent job of this already, I'm thinking about therapies that are going to have an impact on the morbidity associated with the illness, and that's proven through clinical trials, many of which we're going to talk about tonight. And so we have therapies that are going to have a direct impact on the viral replication cycle. And so right now we have one oral therapy, which we're going to focus mostly on tonight, which is Middlesex Bratanovir, but imminently we will also have Molnupiravir as another oral therapy that may be available to our patient population. We have for a bit longer been using other therapies like Sotrovimab. Remdesivir has also been proven to be effective in the Pine Tree study. Unfortunately, our ability to administer that therapy is not as great as we'd like it to be. And then we also have some evidence to support the use of fluvoxamine through the Stop COVID trial, as well as a Together trial. And then I will personally endorse the use of budesonide, which is proven through the STOIC trial to reduce emerge hospitalizations, but also very beneficial for patients who have respiratory symptoms. And that's not to say that we can't be prescribing for improving patient symptoms as well. I know many of you have written prescriptions for Gravel. I've written a lot of Dancitron prescriptions as well. So not to miss those other important things that a patient with COVID may benefit from to make themselves feel a little bit better. Next slide. All right, so as we think and talk about the different therapies tonight, I sort of have different baskets in my head. And so we have access, although it's a bit, we're going to talk about access later to monoclonals. For the monoclonal du jour right now is Sotrovimab. There are new monoclonals that will likely be produced to support different variants as they evolve. So it's good that we think about that as a potential option for patients. Next. And then we're also talking mostly tonight about things that are going to impact on the viral replication cycle. Next slide, or next. We also have therapies that have been studied and are not effective. And so I have patients still to this day asking for ivermectin for their disease, but we don't have the evidence necessarily to support that. Next slide. So in terms of mechanism of action, in terms of the viral replication cycle, I know Rita will be talking about this as well. We have our nirmatrelvir and ritonavir, which we're going to call Paxlovid moving forward, which is a protease inhibitor. And then we'll also touch a little bit on Molnupiravir, which acts on the RNA replication piece, acting on RNA-dependent RNA polymerase. Next slide. And this is not to forget about the other therapies that are more used in the later stages of illness. Next. And so we're still using many of these therapies in hospital right now, including dexamethasone, tocilizumab, and baricitinib. Next. So with that, we're going to get into, go to the next slide, please. focusing on some of the clinical trials to tell us about the benefits of these oral virals. And then we're going to talk on who qualifies for them and how we're going to access them. And I'll take it away, Dr. Elsayed.
All right, thank you, Megan. Hi, everybody. Thanks, Vinny, also as well for your introduction. So I'm going to go over the pivotal clinical trials related to the main drugs that Dr. Devlin just talked about. So I'll just, can you go to the next slide, please? Okay. I just want to mention that we're mainly looking at the early phases of illness. So patients who have mild to moderate illness would be kind of the ones where we would be looking at initiating some of the therapies that I'll be talking about. Next slide. This is just a very short article in the New England Journal of Medicine showing all the different treatments that Dr. Devlin mentioned, and then the ones that aren't crossed off are the ones that are left over. So we still have some treatments left, but Dr. Devlin already covered these. So next slide. Okay, so I'm just going to be talking about the top 4 in the list here in terms of the most important papers or paper related to demonstration of the efficacy of these agents. So I'll talk about the key trials. Yeah. Oh, sorry. Just if you can go back. Yeah, the key trial related to Paxlovid, Sotrovimab, Remdesivir, and Molnupiravir. Very hard to say sometimes. And I'll skip over the other ones. Next slide, please. Okay. So this is the Paxlovid trial, finally got published in the New England Journal of Medicine just 2 weeks ago, looking at the use of this agent in preventing progression of COVID in high-risk outpatient adults with COVID-19. Next slide. Okay, so this study was called the EPIC HR, or high-risk study. It was an industry-sponsored, multi-center, randomized trial. It involved 202 study locations. None of them were in Canada or the UK or Australia. They were mainly in the United States and other countries around the world. This was an unvaccinated population. The study ran from July 16, 2021 to December 2021. So this would have overlapped the Delta variant of COVID. They looked at Paxlovid versus placebo. This was a 5-day treatment in patients who had one or more high-risk conditions. They had to have symptoms within 5 days of presentation to get the drug and to be enrolled in the trial. And all of these trials, you'll note, have a composite outcome as a primary outcome. They're not looking at death only or hospitalization only. They're looking at the composite of either death or hospitalization. And usually the trials, all the trials I'll talk about, they're usually looking just in the first month from the time that they get randomized. Next slide, please. Okay, so in this study, in this EPIC HR study that was just published 2 weeks ago, these were the high-risk groups that were included for the most part. Now, there were just a handful of other patients. So there were some patients with cancer, immunocompromised, HIV, but those were probably like less than 25 participants. These accounted for like 95% of the participants, including some people who didn't seem to have these conditions, although the paper didn't really give too much details. But these are the main ones: BMI elevation above 25, hypertension, diabetes, cigarette smokers, current smokers, cardiovascular disease, and COPD. Next slide. Okay, so these were the results from the trial. So if we look at Paxlovid and placebo, there was roughly about 1,000 patients in each arm of the study. They looked at the number of events, and again, this was hospitalizations or deaths. So there were 8 events in the Paxlovid group and 66 in the placebo group. Almost everybody who died during hospitalization in the placebo group. But in general, you can see that the event rate was about 6.3% in the placebo group, and sorry, it should say 0.77% for the total number of events. So you can see the difference. The relative risk reduction was 87.8% in favor of Paxlovid. The absolute risk reduction was 5.53%, and the number needed to treat to prevent one event with Paxlovid, was 18 subjects based on this trial, which is actually pretty good compared to other treatments that we have. Next slide. So that's a summary of the Paxlovid trial. The next one we'll be talking about is called the Comet Ice Trial. It is looking at Citrivimab, same kind of indications as Paxlovid, but it's an IV antibody. Next slide. Also, again, published in the New England Journal of Medicine. This was also industry sponsored, 583 participants. We did have trial sites in Canada for this study, and also the US, Brazil, and Spain. They looked at IV Citrivimab versus placebo. Again, same patient population as the Paxlovid trial. This study was done a little bit earlier. It was done from August of 2020 to March of 2021. And again, they looked at the same composite outcome. They went to day 29 instead of 28, but same composite outcome. Next slide, please. Okay, so the high-risk groups here were a little bit different than any other study, but almost the same. Diabetes and obesity were included. They didn't have a lot of people who had hypertension or smoking specifically. It was a smaller study, but they did include people who had asthma and also people who were over the age of 55 years. The other study did as well, but they categorized them as high risk here in the study. So you can see here the numbers are smaller. There was roughly 1,000 in each arm in the other study, but Comet Ice had almost 300 people in each group. The number of events was very small in total, 1% in the Citrivimab group and about 7% in the placebo group. And again, you know, the number of deaths was very small. There's only 1 death in the placebo group and 0. So there's really, can't really compare the two. But the relative risk reduction was about 85.7% in favor of Citrivimab. The absolute risk reduction was 6% from the baseline risk in the placebo group. And the number needed to treat was roughly similar to the Paxlovid group. It's a little bit better, it is 16 here. So both studies had statistically significant results for in favor of the drug that was being examined, Citrivimab and Paxlovid for the other trial. Great, next slide. Okay, again, New England Journal of Medicine paper. This was just published just 1 month ago. Now, there were previous papers, as you know, with remdesivir when it first came out, but here, this is looking at remdesivir to prevent progression to severe COVID in outpatients rather than using remdesivir for treating patients who are already hospitalized. So this was also an industry-sponsored study. This was called Pine Tree, and it involved 64 trial sites in the US, UK, Spain, and Denmark. There were no sites in Canada. They looked at IV remdesivir. I won't mention the dose. There's a loading dose on day 1 and then 2 days after that, compared to placebo. Again, in unvaccinated outpatients, in this group, they studied people over the age of 12 years versus the previous 2 trials I mentioned, which only studied individuals over the age of 18. And in this study, they looked at people that had symptoms of COVID less than or equal to 7 days rather than 5 days in the previous studies. This study, again, almost overlapped the Comet Ice study in terms of the study period. It was from September 18, 2020 to April 2021. And again, the primary outcome was similar: COVID-related hospitalizations or death from any cause. And the death from any cause was also mentioned in the other studies. Next slide, please. Okay, so their high-risk groups were also similar to Comet Ice and to the first study with Paxlovid, with the EPIC-HR study. So obesity, hypertension, diabetes, cardiovascular disease, COPD, and there were a few other ones here as well. Next slide. Okay, so here we're looking at remdesivir versus placebo. You can see that the number of events in the remdesivir group was very small. It was 0.72% or 2 events in total. And in the placebo group, it was 15. There were no deaths in either arm. And the relative risk of the event in the placebo group was a little bit smaller than in the previous 2 trials I mentioned. Nevertheless, the relative risk reduction was 86.5%, very similar to the previous trials. The absolute risk reduction was about 4.5%, and the number needed to treat was 22. So you can see Citrivimab, the Citrivimab trial had a number needed to treat of 18. The Paxlovid trial had 16 for the Citrivimab trial, 18 for the Paxlovid trial, and 22 for remdesivir. So pretty similar, pretty similar. Next slide. So we'll talk about the final set of data for the last drug that we'll talk about, which will be molnupiravir. And this also was published very recently in the New England Journal of Medicine, less than a month ago. And it looked at, again, non-hospitalized patients with risk factors to progression. Next slide, it's called the Move Out study. This was also industry sponsored. There were about almost 1,500 participants. There were 78 trial sites in 15 countries. And they looked at molnupiravir versus placebo, again, in the same kind of patient population that the other studies did. And they were, obviously, you had to have at least one risk factor in this study. The study period overlapped the study period with the EPIC-HR trial, which kind of overlapped the Delta variant of COVID. So it was May 2021 to November 2021. And again, same primary outcome. Next slide. Okay, these were the high-risk groups. Now, the BMI category here was slightly different than in some of the other trials I mentioned, but age, diabetes, asthma were also included. There were others as well, but they were very, very small proportion. Next slide. Okay, so I think there might be 2 slides after this, and then we'll wrap up. So molnupiravir, if you look at the number of patients and the number of events, it was very significant. Like, it was very impressive in terms of the number of events compared to all the previous trials. When you looked at Paxlovid, Sotrovimab, Remdesivir, they had a small number of events. Here, proportionally, much higher event rate, 6.77% versus almost 1% in the previous studies I mentioned. Now, the placebo as well didn't fare better, it fared worse. Their event rate was about 9.7%. The number of deaths in the placebo rate was 9 compared to 1 in the treatment group. But when you look at the relative risk reduction, it was 30.4%. Now compare that with like 85, 86, 87, 88% with the other 3 drugs. The absolute risk reduction was 2.96%, but the number needed to treat was 34. And this study, actually, the results, they did an interim analysis initially, and then they had kind of more data afterwards. And when they did the analysis with their full data set, the results really didn't reach statistical significance, or barely, was right at the borderline. And so you can see that there's a difference. It doesn't mean that this drug doesn't work. As you can see, there is a difference. We might have more information. It's approved in the UK and it's being reviewed in Canada and the States, but I won't talk about that part. But anyways, you can see that it didn't fare as well compared to the others. Next slide. I just wanted to show this graph. This was taken from, I think, CTV News. I had some other photographs here. You can see that these peaks or humps relate to the waves of COVID, and I didn't label them, but the last peak there is the Omicron peak. And none of the trials were done during that peak, obviously. A couple of the trials were done during the Delta peak, which was roughly from July to December. That would have been the Delta. And then there were some other variants before. I won't go over that because of time. And these are the number of cases per day during different days in those time periods. So Omicron certainly had a big impact in terms of numbers. Next slide. Oh, that's it. So anyways, that's the end of my component. I think, is it Megan that's on again?
I think Rita's
Dr.
up.
Devlin? Oh, Rita's up. Okay.
Yeah.
Thank you, everybody. Yeah.
Thanks, Dr. Elsayed. So based on, next slide. So based on that data, Health Canada expedited a review and an approval for Paxlovid, specifically in mild COVID patients, and in those, again, specifically who are at higher risk of hospitalization. And we'll talk about how we define that risk shortly. Want to be clear that the approval is not for patients that are moderate to severe who end up hospitalized or requiring oxygen that is above what their baseline oxygenation status would be. And it's also not approved for pre-exposure or post-exposure prophylaxis, as well as the drug duration is intended to be limited to 5 consecutive days. Interestingly, the US actually did approve an indication for pediatrics. However, the Canadian emergency authorization for this drug only allowed for patients that are adults over the age of 18 and over the weight cutoff of 40 kilos. Next slide. So in terms of how the drugs actually work, again, there's 2 components that we've talked about. The nirmatrelvir, so both of them are protease inhibitors. The nirmatrelvir is actually the first SARS-CoV-2 targeted protease inhibitor. It targets the 3CL protease enzyme on the virus that will, again, ultimately interrupt viral replication. The ritonavir, also protease inhibitor, which you will recall, is an HIV protease inhibitor. It actually has no direct effect on the SARS-CoV-2 virus. You might recall that ritonavir is known for having very strong CYP3A4 inhibition and a number of drug interactions. And so that's actually the precise case here. Nirmatrelvir is a substrate for CYP3A4. So ritonavir actually prevents the metabolism of nirmatrelvir, thereby increasing its concentrations and prolonging the half-life of the drug. So it actually just works as a booster. Next slide. The drugs are actually not co-formulated. It is actually available in a kit, which contains actually 5 blister cards with the 2 drugs packaged separately. They, again, are co-administered and should be initiated really as soon as your COVID diagnosis is made. And we really are aiming for within 5 days of symptom onset. Again, trying to catch sort of the timing of the virus when it's in its highest, rate of viral replication. Although it's actually just both of them are film-coated tablets, it's actually suggested to swallow them whole and not crush or break or chew them for administration. And generally speaking, the drug is very well tolerated. There are some mild GI upset, taste disturbances, headaches, and myalgias that have been reported by patients. Next slide. So the standard dosing is 2 tablets of nirmatrelvir and 1 tablet of the ritonavir taken twice a day just for a 5-day regimen. There is renal dosing adjustment that is required on the nirmatrelvir component. And if the patients either have severe liver or renal impairment, the drug is actually not recommended. That needs to be a part of our screening process when we're assessing patients for the drug. Next slide. I thought I'd also mention, again, there was no specific human safety data in pregnancy or lactation. There is a little bit of animal data available that is suggesting that there's no concerns. However, there hasn't been an official pregnancy categorization assigned yet. I mentioned the thing about pediatrics and the Canadian labeling not actually being officially authorized for pediatrics. And so far, there hasn't been any concerns identified in the geriatric population. Next slide. So one of the biggest issues that we have with the Paxlovid itself is an assessment of the drug interaction. So again, I wanted to just re-highlight that nirmatrelvir, although acts as a potential inhibitor, it is primarily a substrate at the CYP3A4 enzyme, and ritonavir is a very strong inhibitor of 3A4 and to some extent 2D6 as well. So this again does lead us to have a more thorough assessment of drug interactions before initiating the therapy. Next slide. The Ontario Science Table actually has developed a very helpful drug interaction resource. I wanted to make sure that everyone was aware that there is a document that is on the Ontario Science Table website called What Prescribers and Pharmacists Need to Know. So it was just actually updated at the end of the week last week to stratify, again, not every single drug that a patient might be on, but the most common things are listed on that drug interaction resource. And it really stratifies those drugs into sort of absolute contraindications as black, and then sort of your red, yellow, green considerations for drug interactions. And they've added a supplemental appendice as well for some of those black and red drugs that will actually help sort of triage and determine what some of your next steps should be in terms of trying to co-administer if you really wanted to or had to. Next slide. I did want to highlight, again, sort of the category of the absolutely contraindicated drugs. Again, these are not to be co-administered due to the risk of serious toxicities. Stopping the drug doesn't actually mitigate the interaction. So again, these are going to be scenarios where the half-life will be prolonged. There's a very narrow therapeutic index, and that prolonged enzyme-inducing effect or inhibiting effect from the ritonavir will result in potentially some harm to the patient. So again, not surprisingly, some of your anticonvulsants and antiarrhythmics are on there. The phosphodiesterase inhibitors, again, specifically for the patients who use those for pulmonary hypertension, I think that's where we really get concerned, where they have who require daily use of those agents. And kind of the other class that I would probably sort of flag is those transplant patients that are maintained on the calcineurin or mTOR kinase inhibitors. There are some recommendations from the American Transplant Society to consider some of our alternate COVID therapies like remdesivir, like sotrovimab in that early 5-day window period where possible, before we consider adding Paxlovid, because we know that the drug interaction will result in substantial increases in drug concentrations of those particular agents. Next slide. I thought I'd also just quickly highlight some of the additional contraindicated drugs that are sort of more in the I'll call them red category, because in some scenarios, although the co-administration could potentially be risky, there may be scenarios where you can actually hold these agents for 5 to 7 days or replace them with an alternative. So for example, if you had the capacity and you were using rivaroxaban for VTE, potentially you could substitute dalteparin for 5 to 7 days to ensure that there was no concern around increasing the levels too high. Next slide. So again, quick summary. Again, in terms of the pharmacology, we've got dual protease inhibitors, one acting as directly on the virus and the other acting as a booster. We're targeting those mild patients within 5 days of symptom onset. Renal dosing and hepatic impairment, again, are going to be a bit of a concern and screening process. We'll have to include best possible medication history that not only includes their prescription drugs, but their over-the-counter and herbal therapies as well. Next slide. Just for comparison, again, I wanted to sort of highlight the differences with molnupiravir, which is again on the horizon and hopefully will be here in the coming months, pending and Health Canada approval. In terms of mechanism, molnupiravir actually acts as a nucleoside analog. So again, very similarly inhibits viral replication, but it does that by sort of promoting mutations during the replication cycle of the viral RNA. Very similarly, we're looking to use this drug in early patients within 5 days of symptom onset. It does require a significant number of tablets for the patient to administer, 4 tablets in the morning, 4 tablets in the evening, 5 days therapy as well, but there's no concerns around renal or hepatic impairment, and the dosing remains consistent in those scenarios. There are some early warnings and early signs in some of the initial pharmacokinetic data that there may be some impact on bone and cartilage toxicity, and there is a significant amount of drug that passes through the placental barrier. And so there's, again, in animal models, been some flags about fetal toxicity. And so right now there won't be a recommendation for pregnancy or pediatrics. And in terms of tolerability, again, this agent is, again, very similarly well tolerated. Most common adverse effects are related to GI and just some mild dizziness. I think Dr. Elsayed did a good job of highlighting the clinical data from EPIC-HR and the Move Out trial. So I think that's all I've got from my end.
Okay, thanks, Rita. So we're going to talk now about who of your patients should be receiving some of these COVID-specific treatments that we've spoken about. Next slide. So as you guys know, keeping up to date with all the new information about COVID is a full-time job. And we have gone through many iterations of our guidelines, and primarily we've been utilizing the Ontario Science Table guidelines. And they've just come out with a new set of guidelines as of last week. And frankly, they've made it a little more confusing. So every time I get a handle on things, they change it. And obviously this is very small, so we're going to go to the next slide. But what I encourage you guys to do as prescribers is, if you aren't someone who is doing this a lot, that you actually just go to the Ontario Science Table website so that you're using the most up-to-date guidelines that they have available, because I don't know when the next set is going to come out. And it's best that you're going directly to the source. And that's easily able to find on the internet. So we're going to look at what we're using right now. And as Rita alluded to, what we're trying to decide is my patient at high risk of being hospitalized? And as we've moved through COVID, we have a better understanding of who those patients are, particularly patients who are elderly, who have comorbidities, many of which Dr. Elsayed noted as high-risk conditions in the different trials that we've talked about, and then also immunocompromised individuals as well. So we have this table, which is a little bit confusing, but we're going to sort of use an example of a 70-year-old patient who has not received a vaccine. So if we go to our chart down here at step 1, we can see if the patient is over the age of 70 and has not received any doses of the vaccine, they would be deemed high risk. If we have a 70-year-old over the age, or sorry, a 70-year-old who has received 3 doses of the vaccine, then we're also looking to see if they have associated risk factors. And if that patient is diabetic, has hypertension and obesity, then they also should qualify for these treatments. So that's how we're working with that. I would highlight as well that we're going to speak a little bit about our immunocompromised population, but we are also identifying priority populations. So this includes Indigenous people, Black people, and members of other racialized communities who also should be considered for treatment as they are going to be at higher risk of morbidity from the illness. Next slide. Many of you have patients with immunodeficiencies, and if you go to the fine print of that document, you will find these criteria for who qualifies as a significant immunodeficiency. So this includes patients who have cancer on treatment, who are transplant recipients, who may have HIV or primary or otherwise immunodeficiency. And then many of you have patients on other immunosuppressive therapies, maybe prednisone, maybe TNF-alpha inhibitors. And these patients also would be considered higher risk as they're not going to mount an immune response. Next slide. So what we're really trying to decide is, as you guys are primary care providers and maybe the first point of contact for these patients, and Gord's going to talk about how we access this afterwards, Dr. Schacter, sorry. And we are going to be thinking about A, how many days of symptoms has my patient had? And then B, whether or not there are drug interactions that are going to preclude the use of Paxlovid as our sort of first line treatment for these outpatients. So we'll go to the next slide. So what we're going to say is if we have a high-risk patient, using that table that we've just looked at together, we have someone who's within 5 days of symptoms and does not have any major drug interactions. We're going to be thinking about prescribing Paxlovid, and Dr. Schacter is going to talk about how we do that. If they do not meet criteria for Paxlovid, then likely our second option is sotrovimab. And how we access sotrovimab is not perfect or streamlined right now. If it's a transplant patient, often these patients are identified by their transplant teams, and then our transplant ID colleagues are able to arrange that. We've also been prescribing it through the LUC3 clinic as well, and those patients all come to LHSC for OPD. Unfortunately, LUC3 will be closing at the end of March, so we're looking at other avenues for getting this for patients. There are communities that are not London that have sotrovimab as an option. We're trying to get London to be one of those as well, but that isn't in the cards at this exact moment in time. So these are sort of what we're thinking about prescribing these patients who are early in their disease course and are high risk of coming into hospital. Next slide. I stole this summary slide from a presentation from the States that I was just watching last week, but it helps to summarize these outpatients that we've already gone over together. So we know through Dr. Elsayed speaking to us that efficacy for Paxlovid, sotrovimab, and remdesivir is good. Ease of delivery, obviously, because this is an oral drug, is going to be best with Paxlovid, but we worry about drugs interactions. And then the pregnancy piece is an issue in and of itself. Really, the only drug that I've prescribed to pregnant patients of these 4 drugs has been remdesivir. And then we'll ignore the authorized for children because this is an American slide. But that just helps us to sort of summarize the pros and cons of each of these therapies. And I think that's it for me.
Thanks, Megan. So we're going to move into have a better understanding how locally we can get antiviral therapies for our patients. So we'll go to our next slide. So this is just a bit of a pathway, or if you want to call it that Ontario Health put together. And my talk is going to follow this pathway because it made a lot of sense to me. So the first part is we need to be able to have a method of communicating to our patients who is at risk and making sure that they call us. And so when they call us, we need to be able to prioritize and get them in for some type of assessment, preferably within a 24-hour period of time. We need to know how to assess them, what type of tests we need to do, when to refer them on if they're appropriate for therapy, and then the need for follow-up. So I'm going to go through this a little bit further. The direct referral is part of this, but the idea here is each individual sort of region across the province may have slightly different pathways based on the way their clinical assessment center is set up, their access to these drugs. So that's why we're going to talk about our local area. You can change the slides. When I talk about our local area here, our local area includes the county of Middlesex, counties of Oxford, Elgin, Huron, and Perth. And that's sort of the catchment area right now for our Paxlovid treatment, which, as I'll mention shortly, there's central pharmacy for distributing Paxlovid will be through the London Health Science Centre Pharmacy. So when we talk about communication, we want to make sure that we have an understanding of the criteria, but that we also communicate to our patients who are considered high risk of severe disease. And I think it's important for us to do this, but there's also going to be important for the public to have some public media awareness. So we do have some plans in place to do some, there's a weekly press conference that the Health Unit and London Health Science Centre does with the media, which is on Tuesdays. So for next Tuesday, there will be a press conference that they'll try and get some of this messaging out to the public. There was some discussion I was at today with Ontario Health West about this need to be larger and whether the province is getting involved, but we'll see where that goes. Ultimately, public health is probably one of the best positioned groups to understand how to get large public messaging out to change behavior. And we really want to engage public health and that behavioral change expertise for it. Also, we know that our public health colleagues have been the major voice for COVID in the last 2 years. And so there are people who are actively listening. There's people who's actively criticizing too, but there's a lot of people actively listening. So we're going to sort of leverage that sort of relationship. When we talk about engaging patients, so I saw somebody today who's a cancer patient who was actually asking me her opinion about whether I felt it'd be good for their large family of 7 to get together for her husband's birthday next week and her risk. So I talked to her about that, but I also mentioned to her that because of her ongoing cancer therapy, she's actually a candidate for Paxlovid if she was to get sick, because she's actually in her late 60s, so based on age she is too. So I wanted to make sure that she has an awareness. So even despite that, she knows that if her symptoms come on, that she should be calling myself as soon as possible to get her access to those drugs. We want to have those conversations with patients. We can look at doing mass email blasts or targeted email blasts if you understand how to search your EMR for these patients who are on immune compromising drugs. You may be able to do some targeted email blasts to them. If you have a practice website or online booking portal, updating that. If you do social media, because I know some people have office Facebook accounts, using that type of tool, and then just even creating an educational handout. I put a tool in here, which Vineet may, if I can ask him to put the link in here, and I'm going to let people know that this tool is actually a little bit of an old tool because it was up to date up to last Thursday when they changed the criterion. But I want people to be aware of the Confused About COVID website that U of T's put out, because I am assuming they're going to update this very shortly and we'll have good handouts for us to use for patients. The challenge that we had in getting this town hall together really came as of Friday when we found out the Ontario Science Table changed their criterion. And there's been an incredible amount of work by the teams, by the Clinical Assessment Center, by pharmacy, by our speakers today to try and get a huge pivot and shift to make sure we have this talk available for you today and even some draft templates that you can use for doing these referrals, which we'll share shortly. Next slide, please. Prioritize. So really, if a patient identifies themselves and calls your office, it's really important for you to have an awareness, but also your office staff. I really don't want to downplay the need. It's one thing for us to be aware, but if our office staff don't have any awareness, then these patients don't get past that front door. They don't even get to talk to you sometimes for a day or two, and that's going to potentially miss out the opportunity. So educating your staff, the type of patients to look for, the type of symptoms to look for, because now it isn't just stay home and isolate yourself. It's identifying that you actually may be a candidate for treatment and ensuring those people get to be seen. So ultimately, if you can have some type of assessment, whether it be virtual or in person within 24 hours, would be important. There's a script here that we're going to put in also in the chat, which is just some script for us to help our medical office staff talk with patients about COVID. So Vanita, if you can put that link in, that would be great too. Next slide. So how to assess the person. So again, doing a virtual or an in-person assessment within 24 hours. However, recognizing if this individual has severe symptoms, so really you're significantly short of breath, having difficulty talking, whatever it may be, they should be going to emerge. You shouldn't be trying to spend time doing the virtual assessment or looking at getting them into your office. You really need to still identify those people who need rapid assessment and potentially a 911 call. You need to think about their patient eligibility. So their criterion, are they significantly renal impaired? If they're on dialysis, they're not going to be a candidate. If their GFR is less than 30, they won't be a candidate. If they have a significant liver disease, they won't be a candidate. So thinking about that, despite the fact that they may have eligibility, what's their exclusion criterion? Then ultimately they need to have a positive COVID test. There's different ways. And then the preference, this is what's suggested by Ontario Health now. The first preference would be getting an ID now. The ID now is what's called a rapid molecular test or a rapid PCR test. Our clinical assessment center does have access to the ID now. They can get a result within about 15 minutes. So this would be the one place they could get this test. The second option is a rapid antigen test administered by healthcare professionals. So just because your patient says they've had a positive rat at home, that doesn't qualify them. You need to do that yourself in the office. And there's a lot of us who are still seeing these symptomatic patients in the office. The key is, do you have access to rapid antigen tests? And I know there was a question in the registration that came out, how do I get access? So down below, we've put the website, the HMMS portal. So this has been the same portal for you to get free PPE. So if you want to ensure that you have free PPE, including N95 masks, this is all available on the N95 on the HMMS portal, and you can order the rapid antigen test. I know they were not available in December when everyone was trying to order them, but they are available now. There was a huge shortage initially, and they've got large supplies now. I know our office about 2 weeks ago received, because we ordered in December, suddenly 25 boxes suddenly arrived. And so that's about 100 tests. So we actually have a lot in our office that we're going to share amongst the number of physicians. So just making sure. However, if you do the rapid antigen test and it's negative, it is suggested that you do a PCR as well, because that could be a false negative. And we could always get our specialist, Dr. Devlin or Dr. Elsayed, to make their comments on the chances of false negative and positive and rapid antigen testing, because we know that they are not the foolproof test. But recognizing that if you have a positive, you can probably refer on for therapy, and I'll tell you how to do that shortly. And then the third option is a lab-based PCR test. And recognizing that if you send this to the outpatient labs, the Gamma Dynacare or the Life Lab locally, it depends on what their turnaround time. My experience has been a little bit more than 24 hours. So that's, you have to look at a patient presents in day 3, this could be an issue in getting them drugged by day 5. So recognizing the timing of when their onset of symptoms are. Next slide. So refer. So there's 3 clinical pathways that we've organized here locally for getting patient drugs. So we'll go to the first pathway, next slide. The first one is that the family physician, nurse practitioner, or the primary care provider does an in-person assessment and does the test. So this could be the rapid antigen test and or the PCR. And assuming that it's positive, then they can do a referral directly to the London Health Centre pharmacy using the Paxlovid referral form, which we'll share with you shortly. And I know Vineet will probably put those in the chat for us. The form that we're putting in the chat literally was finalized about 4 o'clock today, and it is a fillable PDF right now. These forms will be available on the Clinical Assessment Center website within the next 24 to 48 hours, which is the COVID testing LM.ca website. There's going to be a separate tab for professions, or I'm not sure what their terminology will be, where we can go in and download these forms. We are going to try and get them converted to an EMR friendly version as soon as possible. Literally, these forms were finished completed today because of the new criterion that changed last Thursday. We had them all ready until that showed up. So there's Vineet putting that Paxlovid form. So you can download that from the Zoom chat and save that if you want to print it out for your use. So when they get that referral form, the LHSC pharmacy, they will contact the patient and do a full meds review their meds to ensure there's no contraindications or advice on what they may need to change. If there's some concern, the LHSC pharmacy may contact you at your office, and that's why you're going to be putting your phone number on the referral form. And then they will directly courier the drug to the patient. So we're going to go on to pathway number 2. And we're going to look at the option here is that the family physician, nurse practitioner, or the primary care provider does a virtual or in-person assessment. Then they can refer to the Clinical Assessment Center for the ID Now testing or lab testing on its own using the referral form. Then the CAC will provide you, the referring provider, with the results of the ID Now and the lab results that you need. And then you yourself as the provider can do the antiviral referral form or the Paxlovid referral form from the pharmacy and take responsibility for prescribing the drug yourself. So this is just an option for those of you who don't feel comfortable doing the swabbing in your office, or if, let's say, we've set in the pharmacy form that they should have an updated GFR within 6 months. And if you don't have an updated GFR, you think that's needed, or you're concerned that they need a lab pregnancy test, or you want to test their liver status. And these are things that you can't send them to the Gamma Dynacare Life Labs. They would need to go somewhere. So we've arranged for the CAC to be able to do blood work and rapidly get results from LHSC POM lab. So this way you can make the decision yourself to prescribe, send that pharmacy referral to LHSC, and then the patient gets contacted, and in turn the drug gets sent out. So this is the second pathway. The third pathway is next slide over. Would be you do the initial assessment or contact with the patient. You do a referral directly to the Clinical Assessment Center. Well, they will do the assessment of the patient, the testing, and make a decision if they're a candidate for antiviral, and then send a referral to LHSC pharmacy, who will do the meds reconciliation and then courier the drug to the patient. We've created the 3 pathways for a purpose. I want to ensure that any family doctor or nurse practitioner or primary care provider out there who wanted to take responsibility had the opportunity to do so. We also did that because we know as the potential for the liberalization of criteria for treatment comes out, we have to look at capacity in the Clinical Assessment Center for them to see everyone. And the reality is that may not be there. And so this is a potential, making it a way that family doctors can do this in their office and if they want to. We know that some of us have not been seeing symptomatic patients in our office, but a lot of us have been seeing symptomatic patients at times. And so we have the opportunity and the option to do that testing in our office and then do the initiation of the drug themselves, recognizing that we do have that backup with the pharmacy. And if we're unclear, you will have contacts for the LHSC pharmacy as well that you can talk to the pharmacist who's going to be doing this work. So we'll go to the next slide, please. So this is what the Paxlovid prescription form looks like, and I know it's small. So what I've done is I've gone to the next slide to blow up the top half just to show you what this is going to look like. So in the top, we have their demographics, patient demographics. We've done in these specific boxes, so when it converts to an EMR, it'll be very EMR friendly. We created this sort of risk stratification where you say, are they immunocompromised? Are they unvaccinated? What their age is? Are they vaccinated with 1 or 2 doses? What's their age? Are they vaccinated with 3 doses and what's their age? And this is meant to get you to understand the sort of that inclusion criterion. But if they have to have that risk factor, we want you to check off the risk factors. So the boxes on the left are going to check off the risk factors. The boxes on the right would be checking off what is their immune compromised status, so that we all know who's getting treated. And part of this is for statistical collecting. Part of it is so the pharmacist also has an awareness of who the patient is that they're doing their discussion with. Next slide. The bottom half of the slide basically is asking for an attachment of the current medications. Your CPP would be adequate. Preferably, if you know the patient's home pharmacy, this allows the LHSC pharmacist to clarify drugs in case yours are not up to date. They can touch base with their community-based pharmacist to check the drugs carefully. Allergies are always important. We want to know, do they have liver impairment? Do they have kidney impairment? Height and weight are going to be very important in order to ensure that the dosing is done properly, calculated. Creatinine GFR, so preferably in the last, looks like we changed it to 3 months. I thought we said 6 months, so someone changed that along the way. So it is 3 months for that. So this is my first time noticing that. There's a lot of debate out there, so it's interesting across the province that everyone's got different criteria, and ultimately what we're being told, you should use clinical judgments. We try to make it a little bit easier, so we're going to say 3 months. If it's more than 3 months, you probably need a GFR, but one thing to consider, if you have a patient who you think because of COVID, they've been significantly dehydrated, not been eating and drinking well, you may want to consider getting an updated GFR because that dose may need to be adjusted. And then you have the option of ordering. So you have your standard dose or your reduced dose based in GFR. So you check off the box, put your name, signature, date, and send this off to LHSC pharmacy, and they will do their job. So again, this would be for the pathways 1 and 2. Pathway 3 is the direct referral into the clinical assessment center. So again, this is a long form. I've showed you just at very high level here. The top part of it very much mimics what you're going to see on the prescription form I showed you. So I'm going to show you the very bottom part, and which basically is defining our 3 clinical pathways. What is it that you're actually sending them to the CAC for? So the first box is basically an assessment and measurement management by the CAC staff completely. So they will do the assessment, testing, and management, prescribe the drug as appropriate. The second one would just be for an ID now testing only. And then, so if you check that off, we're going to ask you to put your fax number or telephone number so that the CAC can phone you and let you know the results of that ID now test. And then the third is the blood work. So do you need to decide which blood work that you would want ordered from that patient? But it's going to be your responsibility as the referring to provider to follow up on the lab results if they're abnormal. The goal here is when this lab work is done, it's going to go through the LHSC POM lab. It should be sent to you fairly quickly through HRM. That's the goal, and that's what we're trying for. So if anyone does do this and are finding they're having problems with that, please reach out to me and let me know, or make sure that those electronic tools are working properly. But you can always try and do an OLIS poll. We're hoping that these labs should be back within about an hour to an hour and a half from being drawn. So it all depends when the patient actually gets seen, it gets drawn, it gets to get couriered from the CAC, which is Carling, and to the hospital, and then the lab has to be actually, test has to be performed. So there is, those processes are in place. And then at the bottom, we just have the exclusion criterion, which is kind of a reminder for you that if you think anyone meets these exclusion criterion, then they probably should be referred on. So that being said, we'll move on to the next part. Next slide. So the follow-up. So for any of the antivirals, we want to ensure that they have some close monitoring. So monitoring for side effects, drug interactions. So you as the clinician, if you're prescribing the drug, you have to make your clinical decision on when you feel you would want to follow up with your patient, and whether it be in person or virtual. I want to remind people of the COVID at home monitoring, and that also home and community care support services has remote patient monitoring. So if you feel this patient has still the risk of having an O2 sat drop, which is potentially any COVID patient, even despite the fact they're going to get an antiviral, I would consider getting them an O2 sat through the COVID at home program. So the COVID at home program, you order it through COVID at home. Those O2 sats get sent to your office, then you have to make arrangements for your patient to get the O2 sat from your office when they're sick. So whether it be a family member or a friend picking it up, taking to the patient, then you need to have direct contact with the patient. But I've done that. It's been helpful for a couple patients of mine. I've also used the home and community care program. I haven't used that for a little while since I got the O2 sats myself. I wanted to just try communicating that with myself, with my patients, which I found a little bit easier because then I had a better idea, especially in those ones I was worried about. And then if you have any, if you want to have some advice about just general COVID follow-up, the Hamilton Family Medicine website has great resources on the whole management of COVID, and they have one of their individuals keeping up that website on a regular basis. So it's very rarely up to date. So I think I have one more slide. Oh, that's just my questions there. So we're at questions, and I saw people posting stuff in the chat of some questions, but I'll let Vineet, you can kind of moderate that. And my dog came down for a visit.
Sorry for that. I was just getting all these documents in there for you. So yeah, so that's great, Gord. Thank you everyone for a great talk and lots of great great information there. Lots of information. You guys have been working hard to get this out to us. I really appreciate that. So yeah, we do have some questions here from the chat. So we're going to get that started here. If anybody has any other questions, please ask them in the chat or feel free to raise your hand. A lot of them were answered in the talk itself, which is great because I think there's a lot of great information about the practical side of things and how to move ahead with that. I guess there's a few questions just about just the medication itself, and just wondering about compliance factors with 30 pills in a 5-day period and stuff. Has there been any kind of pushback, or is it a lot of side effects that cause people to you know, not complete the treatment, or is there, you know, what do we do about that, I guess, or how do we encourage people to make sure they finish the whole course? I'm not sure who to ask that question to exactly, but I guess maybe I'll send it to you, Dr. Devlin, if you have any thoughts or if you had any experience with patients that have had their course yet.
Sorry, the question was...
It was more about just compliance with the large number of pills in that short time, and is there any like side effects or things like that that have been an issue?
Yeah, so I mean, from the trial data, the actual side effects were relatively limited. And if you read the side effects, they sound a lot like having COVID. I personally have not yet prescribed Paxlovid, so I haven't followed anyone who's on it. So I haven't had any experience with non-adherence to the medication, but it's a short course of treatment. Yeah. And so hopefully people can get through it.
Great, thanks. You mentioned that Dr. Devlin, I'll send it back to you again, just about the pregnancy side of things. And someone had asked in our sign up about, you know, what are the options for women that are pregnant that maybe are at higher risk?
So the options are somewhat limited right now. As I mentioned, remdesivir sort of has some we have some experience using, but typically we've been prescribing it in inpatients because we don't really have a setup right now for outpatient remdesivir. So right now I wouldn't feel comfortable prescribing sort of any of the alternative therapies for a pregnant patient. And fortunately with Omicron, we haven't seen quite as severe disease as we did with Delta in our pregnant patient population. But certainly there are individuals who have been hospitalized, and for those, some of them have received remdesivir.
Thanks. There's a good question here from Arlene McDonald there. Maybe I'll send this over to Rita. For long-term care residents, are the medications able to be crushed?
Yeah, it's a good question. So it's interesting that they're actually just film-coated tablets, but right now on the Paxlovid labeling, it right now says do not crush. So swallow whole, do not crush. So I think we're just awaiting getting a little bit more experience with it and getting some more concrete kinetic data that there isn't an impact on the absorption and the actual concentrations of drug in the blood. So right now, no crushing.
Okay, and then I got a couple of questions just right at the same time about the cost of these treatments. I'm assuming they're all covered, but just curious about the cost in general though.
Yeah, so I can speak to that as well. So many of the COVID therapies have actually been federally procured and negotiated with the companies. And so they were federally procured, distributed to the provinces. So there is not a cost directly to the province for Paxlovid or, like I said, some of the other COVID therapies. The actual acquisition cost has not been disclosed to the public, but for comparison, in the US, a course of Paxlovid costs roughly about $600 for the 5-day course. In Canada, we're not sure what we paid for it, but right now there is not a charge to the patient.
Great, thank you. Sorry, some other more questions coming up in the chat there. So Lisa has a question on the thoughts on fourth vaccine dose for pregnant women since they are immunosuppressed and treatment contraindicated. Maybe beyond our scopes here, but we can always, anyone who wants to take a venture on that.
I would say I don't know that there's good evidence for a fourth dose right now in that patient population. I certainly am recommending third doses in patients who haven't received a third dose during their pregnancy, but fourth doses, I don't know. I don't have an answer on that right now.
Thanks, I appreciate that.
Denise, if I can make a comment, I think we need to recognize that the only groups so far that have been getting fourth doses are the long-term care home recipients. And so, it's a challenge. We have to sort of await sort of guidance from the research guidance from the province. We already need to still do a lot of work on third dosing. We have not as many third dosing individuals out there that we'd like to see. This is my political commentary, but as we see the province open up as of today, we're going to see more and more socialization. And the thing that's going to hold us back still is our first line outside of masking, hand washing, is vaccination. So again, I know we've heard it over and over again, but the reality is it's still not as good as third dosing as we'd like to see. And so always just a reminder for us to, as we're seeing our patients, to continue asking people about getting their third dose. It's very challenging to us as providers to not understand why somebody will get two and not get that third, but you need to look at that. So.
Yeah, no, that's great. Lots of questions coming through. Just a couple of things I wanted to mention too. We do have some extra people that are available for questions that have been kind enough to join us tonight. We've got Lori Loveland and Mariah Zalatak, who are NPs working at the assessment center, as well as Kim Plonk and Jane Edwards, who are helping out with the organization there as well. So if you have any questions about the logistics of the assessment center, please feel free to ask those questions as well. There were other questions about the information here tonight. We will be sending out an email with the links and with the things that have been mentioned here, as well as the things that have been already shared on our chat, and the recording will also be sent out as well. So if anyone that has missed it, they'll be able to get it there. There was a couple of questions I'd seen there. Maybe I'll ask this just for Dr. Devlin again, if you don't mind, or Dr. Elsayed, I guess if you don't want to join in too. One of the exclusions is an O2 sat less than 92%, but this may identify someone who is at risk if it is a premorbid value. Thoughts on that, and what happens in the under 90% patients?
So my personal opinion is if this patient has COPD and their resting O2 sat is already less than 92% and they're within 5 days of symptoms and they don't have other reasons they can't get Paxlovid, I think they absolutely should. I don't know if other people have a different opinion on that, but that's sort of would be my impression. A lot of times in hospital, what we're trying to follow is that a change from their baseline. So if they're on 1 or 2 liters at home already, I wouldn't consider that a reason not to administer Paxlovid if it's still within their symptom onset.
Yeah, I agree. I was just going to say that in the trials, when they looked at patients who were eligible for enrollment, they excluded patients that had very low O2 sats because they were at imminent risk of needing hospital admission. And so their exclusion also for most of the trials was that if someone needed hospitalization within 48 hours, they would be excluded from the trial. So they wasn't a population that was studied, but they did have the caveat that if someone had COPD, as Dr. Devlin mentioned, they would still be eligible if they were on a baseline level of oxygen, but their sats were low or whatever. So.
I guess one other kind of somewhat similar question is those patients that would be considered high risk, like 70 plus and unvaccinated, but aren't symptomatic, just happen to have a test because of a contact and came back positive. Would they qualify in this pathway?
Yeah, I'll leave it to Dr. Devlin. She went through the algorithms.
That's a tough call. It's kind of distinguishing between it's technically they'd be positive. I probably would prescribe it if they're high risk, especially if they're unvaccinated, but yeah, got to think about that one for a second.
Yeah, it's more really good questions here. I mean, if someone is well controlled with diabetes or well controlled with asthma, are they still considered high risk? And do we err on the side of treatment then, or?
Yes,
Yeah.
I've seen many an asthmatic patient be destabilized by their COVID. Absolutely.
And Dr. Elsayed, these studies were all done like before December, right, or December latest, so not much exposure to Omicron. So how confident can we be, I guess, in the trials is one of the questions that came up here. Or how applicable are they to the current variants?
Yeah, I mean, I've spoken to people internationally about this, but I was just talking to someone in the States about this. And, you know, Omicron, the virulence of Omicron is probably 1/4 or 1/3 of the Delta. The Delta strain is believed to be the most virulent strain of COVID that we've seen. So that was during, you know, from July to December, which is when Paxlovid was studied, but obviously none of them studied the Omicron strain. Most people believe that there should be generalizability to Omicron, but again, you know, it's you know, we don't know for sure. We're actually living the experience with giving Paxlovid to people with Omicron now, but we don't have a lot of direct evidence, but I would say indirectly, people believe that there shouldn't be an issue there. The virulence will be different, certainly, and so that's a good thing. Just the caseload obviously was higher, so that's the opposite.
And how are you doing as far as like supply, I guess, Paxlovid? Like, are we looking at, like, I know with this criteria, we are kind of, you know, prioritizing the higher risk groups, but is there a Delta B like a potential for limited like ability to even treat who we want to, given, you know, potential for as we open up and numbers go up, what have you?
So I will take that question. So we had initially a lot of concerns about the volume of Paxlovid that we received in the province, and given that by the time Paxlovid actually got here, we were sort of at our peak of the Omicron wave. So very worried about the capacity to be able to give it to all patients who would qualify. So that's why, as I think was sort of mentioned, you know, if you asked us last week, we would have given you a different risk assessment strategy for patients. This week, again, we're realizing now that we have, you know, some of the other centers have gone live with prescribing Paxlovid, and guys, it's a very narrow group of patients that qualify once you sort of whittle down not just their disease trajectory, but it's all the other components of their renal function, drug interactions, hepatic function. So by the time you whittle away at those that qualify, there's a pretty small group. And so I think we are now sort of at the stage where we have a bit more confidence in our supply. We are, the supply chains for all of the other COVID therapies have actually stabilized as well. We were running pretty short in the month of January. And so I think we're sort of at a stage where we think we'll be good for the next couple of months. We've got molnupiravir sort of on the horizon as well as a secondary option. And so I think what we're sort of anticipating for is, as the Omicron wave sort of dies down, that we actually will potentially get a second order of Paxlovid and potentially molnupiravir. So I think we're anticipating this to stabilize a bit more.
Vinny, to just make a comment. So us locally here in our sort of London site, we're not one of the initial sites that were chosen for Paxlovid when the province first announced. And you know, I will commend and call out our lobbying effort, our senior leadership, London Health Science Centre, that really went to bat to Ontario Health and the province of the oversight when we look at the location in where we are, where it was Windsor, Kitchener, Hamilton were chosen, and our area was not. But the fact that we have a large transplant population, large immunocompromised population, a lot of the patients who live in Windsor, their transplant specialists are all in London and often are going to get their drug through their London specialists. So, so we are a couple weeks behind some of the other sites. So the other thing we have is the opportunity now to learn from the other sites, and having talked with them at a couple conferences that have been on Ontario West, one of the big things that have been seen is that people are showing up too late, way later than their symptoms, whether it's self-referral, which there is that option of self-referral, which we have not put up the phone number for the assessment center to be able to do. And the reason for the self-assessment is especially for those patients who do not have access to a primary care provider, that they can self-refer on and still get that drug. So it really stresses the importance of the need for education of our patients and the public education, as I mentioned. When people are showing up way too late, and so I've been entrenched in this for the last 4 weeks with this work, and had a patient last, I can't remember, it was Wednesday or Tuesday call, when I knew I could have potentially gotten the drug because I'm in the background, who's a rheumatoid arthritis patient on a significant immunosuppressant drug, who didn't phone us till day 9 of her symptoms, right? And I'm thinking, oh, we could have done something for you, right? And despite that, I ended up talking to her on day 13 of her symptoms, still quite symptomatic. And I had to call Megan and say, what do I do with this patient? Because she still had a fever at day 13. And I didn't know what else to do with her. So it was interesting, right? And this is something that could have been prevented. And she ended up going to the Emerge on the weekend. So we didn't avoid that Emerge visit. And that's sad, because we could have potentially done that. And to me, that just stresses the importance for us of really doing public education. So.
Yeah, it's a great point, Gord. I mean, things have changed so much over the course of this pandemic, right? From having people calling us, we had nothing to do or nothing to offer, to, just stay home and just isolate and do nothing. And now it's, going the other way for those higher risk patients. So certainly trying to get ourselves educated and then pass that along to our patients as well is super important. So no, this is very helpful. Thank you. Questions seem to have died down now. It's 8:32. So I think, we've taken up a lot of your evening with a lot of information. I think I want to thank all of our speakers for joining us. Sorry, Gord, have one more comment before we finish up?
Sorry, I just wanted to make a comment. So because of all these changes, there are a couple documents that are going to come out from Ontario Health addressing to primary care. Probably tomorrow they're going to come out. I've seen a draft and made my comments on changes that need to be made. So hopefully that'll come out. But this was Ontario Health West putting out these documents. As I mentioned, that our referral documents will be put on the COVID testing LM.ca website, probably within the next 2 days. So and look for a tab that'll be providers for referrals or something like that. So take a look for that if you want to download it. We're also looking at getting an email blast out to COVID testing LM.ca, not LMC website. So we put that up a few times, Karen. And there'll be some emails that are going to come out where probably we'll potentially use our LMPCA, Oxford, LMPCA here in Perth PCA channels, and potentially also use the OMA channels to ensure that every physician will get at least the letter. We know that everyone doesn't read those letters and those emails, but I know we have 100 people here today and it's dropped off a little bit, but tell your colleagues who were not able to attend to watch for the information. The more we spread it out, the better we do for our patients in our community.
Yeah, absolutely. This is not, we want to spread this information far and wide because it is changing fast and furious. And thank you all for all the work you've done to get these medications here for us and figuring out a way to how to get it to the right people, and for your work and setting up these pathways for us. That's really helpful. And thanks for your time tonight, our speakers, for helping us share this information. It's been really helpful and really important. And I know I've gained a lot of information here tonight that I didn't have beforehand. So thank you very much. Thanks everyone again for attending, and look out for the email with the links if you haven't got them from the chat, and have a great evening and a great week. Thanks so much, everybody.